PaO2 on the arterial blood gas. You think you know what it means, but there's a little bit more we have to learn. But to do that, we have to get just a little bit nerdy. So let's put on our nerd glasses, and as the Japanese would say, 𝗕𝗵𝗄𝗄𝗃. All right, now we're taking a closer look at the PaO2 value, and let's first define what it is. Now the P stands for pressure. Actually, it stands for partial pressure. Why there are not two P's there, I have no idea. But P stands for partial pressure of oxygen. What we're measuring is the pressure of oxygen in the artery. Now pressure, that's an odd thing. Instead of measuring the volume or how many molecules are there, we do measure pressure because of something called the ideal gas laws and Dalton's law of partial pressure. Now, if you're thinking, oh no, what is that? And you probably wonder if you have to go all the way back to chemistry to remember that. No, you don't. Don't worry about it. You don't have to know about partial pressure in terms of Dalton's law. But let me just get nerdy on you just for a moment. Dalton's law of partial pressure basically just said this. The more collection of oxygen molecules, or any molecules for that matter, that we have in a space, the more collective pressure they exert. In other words, we can measure the pressure that the oxygen molecules are exerting in the artery. I need to be careful here. This is not the kind of pressure you're used to that you can see. So it's not like blood pressure where the heart is pumping and the arteries get bigger and the blood pressure goes up. This is a very different and special kind of pressure that's produced by all gas. It's the very same kind of pressure that we might exert out here in the atmosphere. There's 742 millimeters of mercury pressure on you right now. You probably can't feel that because you're used to it, but it is a constant pressure that's just floating around in the atmosphere, and gas exerts a certain pressure. Well, it turns out in the artery that the collection of oxygen molecules there, the more there are, the more pressure they exert, and that's the Dalton's law of partial pressure. So it's fairly simple. Well, we are measuring the pressure coming off of those oxygen molecules, but that doesn't really matter so much because what we're really trying to do is guess how much oxygen is in the artery. And so it directly relates. So instead of counting molecules, we just look at pressure. But this much is true. As pressure of the oxygen molecules goes up, it must mean that there's more oxygen molecules there. So it turns out it's a key value in the arterial blood gas for us to assess oxygenation in a patient. Just so happens they're talking about pressure. Now, right off the bat, let's start talking about the normal values of a PaO2. And the normal PaO2 value for most people is going to be 80 to 100 millimeters of mercury. Remember, millimeters of mercury is a pressure unit, and it can also be torr if you see that from time to time. And so the normal PaO2 value is 80 to 100 millimeters of mercury, and that's what we want to consider when we're asking if the patient has sufficient oxygen in their blood. So if PaO2 of 80 to 100 is normal, then going below 80, that's when we're concerned that they have insufficient oxygen in their blood. Now, some of you might be thinking, yeah, but what about a COPD patient, a patient with chronic obstructive pulmonary disease? And if you're thinking that, it's probably because you're a respiratory therapist or you're a nurse that's already been in healthcare and you've been around those patients and you've had this drilled into their head or your head that they have low PaO2s as a normal value. So I'm going to talk about that, but I'm going to put them off to the side just for a minute. Let's just pretend like we're talking about your normal non-COPD patient. Then their normal PaO2 should be between 80 and 100. If it's lower than that, then we're going to consider that a state of hypoxemia, or we're going to say that they're hypoxic. Think of that word for just a minute. Hypo means below, just like hyper means too much. But hypo means below, and then oxic means just oxygen. And so hypoxemia or hypoxic condition just means too little oxygen in the blood. In this case, we're going to say it's less than 80 millimeters of mercury. Remember, 80 to 100 is normal. Well, now that we know that 80 to 100 is normal, we also need to look at hypoxemia or hypoxic conditions or a low PaO2 value and judge the degree of hypoxemia. And this is also important for the examination for you respiratory therapists who are taking the NBRC exam out there. But it's a label that we're going to put on the degree of hypoxemia. And it really just goes like this. If 80 to 100 is normal, we can classify hypoxemia as mild, moderate, or severe. And to do that, we're going to go down in groups of 20. So instead of 80 to 100, which is normal, we're going to be thinking 60 to 80 is going to be considered mild hypoxemia. Now, I just lied just there a little bit. It's not really 60 to 80 because 80 can't be both in the mild and the normal category. So in reality, mild hypoxemia is really 60 to 79. If it's 80, we're going to say that's normal. And then we go down by another group of 20, and now we're looking at 40 to 59, and that's going to be considered moderate hypoxemia. And then if we go below 40, then we're going to call that severe hypoxemia. I'll talk about this later, by the way. If you're moderate or mild, then there is definitely a solution, a treatment approach, which we will address. But if you're 40 or less, then that's severe hypoxemia. Well, you're probably about to code. And so that's a very severe problem. But we'll talk about what to do in that case as well. Let me come back to the COPD patient. This is chronic obstructive pulmonary disease. And right off the bat, here's what a gas would look like on them. You'll notice that they look okay. Their pH is compensated and their CO2 is a little high, but they're used to having high CO2. Be sure to watch my other video on COPD and CO2 to get more information on that and to understand that better. But notice here that we have a PaO2 of 56. All right, so that's low. Now, if we're going to interpret that, the first thing you want to be careful of is using the word normal, because you might say that that's normal for a COPD patient, and it is. And what we mean by that is that what we do about it is probably nothing. In other words, if they're already on a couple liters a minute of oxygen, we're not going to do anything about that. But especially for the exam and in real life, if you're going to put a label on that, don't use the word normal. Normal for COPD to have low O2 is understandable, but when we're going to interpret that, we're still going to acknowledge that they are hypoxic. This is especially, I think, important for the NBRC examination because you may be asked to label the degree of hypoxemia that you'll see in a COPD. The difference is that they're chronically hypoxic, but that doesn't make any difference. So let's rate this person right here. Remember, we said that their blood gas shows that they have a PaO2 of 56. Well, if we take a look at that 56, if it was 80 to 100, it'd be normal. But if it was 60 to 79, we would say mild hypoxemia. In this case, they're below 69. And so then we said if they're 40 to 59, then that's moderate hypoxemia. And so in this case, that's where this patient would be. So even though they're COPD, and it might be normal for them to be at that low PaO2 level all the time, what we do about it may be nothing. We may think, yeah, that's just where they're always at, so we'll leave them on the oxygen that they're at. But our interpretation for this patient would be moderate hypoxemia. We interpret it still the same. Well, now let's take a look at the treatment of these things. And the thing to remember here is that there are different treatments for different degrees of hypoxemia. And the first thing I want you to know is that hypoxemia or low PaO2 can be caused for several reasons. Not many reasons, but just a few. If we understand how to look at a patient and understand the reason that it's being caused, then the treatment will understand a lot better, and the treatment differs depending upon the reason. So one reason that I'll talk about first is oxygenation or poor oxygenation that comes from poor ventilation. Again, you can watch the CO2 and the ventilation videos as well in my other videos, but what that means is that if somebody is having trouble simply breathing in and out, in other words, they're having trouble getting the gas from here, namely the oxygen, to the alveoli or inside the lung, then certainly they're going to have trouble with oxygenation because there is no oxygen in the alveoli to get across the membrane and into the blood where the oxygenation is supposed to occur. In other words, if you're not breathing enough, your carbon dioxide is going to go up. We're going to think you have a ventilation problem, but it's going to also stand to reason that soon to follow will also be an oxygenation problem. So one oxygenation type of problem is caused by ventilation. Think about that for a minute. If you're not oxygenating enough because you're breathing at a rate of I don't know, 6 or 7 times a minute, and your breathing is kind of shallow, then that's really what I want to fix. I might be thinking in terms of, oh, let's put them on a bunch of oxygen. You could do that for the meantime, just to hedge your bet. But to really treat the patient, what you have to do is increase the degree at which they're breathing in and out. And so that's an important distinction. In other words, if somebody was breathing about 5 times a minute and you thought, well, I'll just put them on a bunch of oxygen because their PO2 is low, so you want to put them on one of these masks right here, that may seem like the right thing to do, but think about it. If I'm not breathing at a high enough rate or a high enough volume with each breath, then it doesn't matter how much oxygen I get to the mask and to their face. If they're not breathing it down, they're still going to remain hypoxic. Because of this, an oxygenation problem or hypoxemia caused from ventilation is the first and most important problem that if we see, what we want to do is get the patient breathing more. Now, I'll go into this in another video, but there's lots of ways to do that. We might just coach them into breathing more deeply if it's after surgery, they're waking up from sedation, or if it gets more serious, we might put them on a machine like BiPAP that breathes for them, or we may even need to just intubate them, put a tube in them, and then put them on a mechanical ventilator. But that's the solution there. All right, a second reason why they may not be oxygenating very well and having a low PaO2 is because there's a problem in the alveoli. In other words, the oxygen's getting down to the alveoli because they're breathing enough. It looks like they're ventilating okay. They don't look like they're in massive distress, but the alveoli aren't working. Now, this is a very complex problem. It could be that the alveoli are destroyed and not participating in gas exchange very well. That would be true in something like pulmonary emphysema. Or it could just be that they're collapsed. That might be true after surgery. Maybe there's less alveoli, and the alveoli there are kind of collapsed and shrunken in, and the membrane's just not stretched appropriately to participate in gas exchange or allow gas like oxygen molecules to get across the membrane into the blood. Whatever the reason, it could be complex. It also just could be lung disease. We don't know the reason, but that's the second category of reason that there could be a problem. And if that's the problem, then we have a whole different set of treatments, which we'll talk about in just a minute. But generally speaking, that if that is the type of problem they have, then we want to expand the alveoli. If there's bad alveoli down there, that's okay. We're going to put them on something called CPAP, continuous positive airway pressure, or BiPAP. And this is just a machine that can blow pressure down them so that with each breath, it's bigger and it comes with pressure. With that pressure that goes all the way down to the alveoli, that little alveolar balloon sac that's about this big is now going to become this big. And if it does, as you might imagine, the alveolar capillary membrane will stretch and more oxygen molecules can make it to the blood. And ironically, this might be the answer even for those patients who have bad alveoli. In other words, if you have some alveoli or some alveolar sacs that are just not built right or they're falling apart, and that does happen, that kind of happens all the time, then what we want to concentrate on is just say, fine, we'll take the alveoli that are good and we'll expand those things as big as we can so that we can have oxygen exchange going on through their alveolar capillary membrane. And so the answer is called CPAP. You may also hear it as BiPAP, which is just giving the same expiratory, positive expiratory pressure along with another augmented inspiratory pressure. Again, that's covered in another video, but you'll probably need to use something like that. Now, I'll get into the nitty-gritty of specifically what you should do based upon the PO2 values here now as well. But before I do, I want to just give you one other caveat. I want you to take a look at this blood gas here. Now, if you look closely at the PaO2, notice that it is above 80. In fact, it's 92. Doesn't that look good? And it looks like the patient is oxygenating well. But in fact, there is an oxygenation problem, but can you tell where it's at? For that, you have to take a look at the hemoglobin. Now, let me tell you about PaO2 just for a moment. Let me just get nerdy with you just for a moment again. And that is that when we measure the amount of pressure of oxygen in the blood, a few people know this, but we're actually just measuring the amount of oxygen pressure that's coming from the oxygen molecules in the plasma. But most of the oxygen molecules are going to be attached to a hemoglobin, a red blood cell. The red blood cell carries most of the oxygen molecules, and that's not what we're measuring when we measure PaO2. However, if there's not very much hemoglobin, what we can have is an elevated PaO2 or a PaO2 that looks like the one I just showed you, which is very, very normal, but they're still getting hypoxic. We're going to call that tissue hypoxemia because the hemoglobin may be very, very low. Normal hemoglobin would be anywhere from 13, 14, 15, 16, right in there. But if you start getting hemoglobin of 9, 7, 6, somewhere around there, you don't have sufficient hemoglobin to carry the oxygen. So this is misleading. You'll look at a blood gas and think their PaO2 is great, but don't quit there. Don't go home. Don't have lunch. You need to look more closely at the hemoglobin. If the hemoglobin is very low, then you have an oxygenation problem, especially a tissue oxygenation problem. What would you do about that? Well, let me just jump to the end there. First of all, you'd probably put them on 100% oxygen, as much oxygen as you possibly could. That's not going to primarily save them, but we're going to hedge our bets right away, and it's something we can do right away. What you really need to concentrate on is giving them more hemoglobin. Now, that may be in the form of whole blood. You have to get the laboratory to prepare some blood for the patient, or you might also just give them red packed blood cells so that you can boost their hemoglobin right now, and that's what you need to do, probably to save the patient and make sure they get plenty of oxygen to the tissues. But that would be the hemoglobin caveat when you see a normal PaO2 and yet the interpretation may still be they're hypoxic. They have tissue hypoxemia because the hemoglobin is not carrying enough oxygen to deliver to the tissues. Okay, but let's summarize the treatment generally. Of course, we'll go into greater detail in other videos on how to treat hypoxemia with low PaO2, but want to just give you a general sense of where we're going with this. If it's a normal patient, a patient that's not COPD, and their oxygen or their PaO2 is 80 to 100, or even if it's higher. Now, if it's higher, I'm probably going to want to turn down the oxygen to make sure it is 80 to 100. Again, I'll talk about that in another video. But it's not very threatening if it's too high. But if it's below 80, then the answer is to give supplemental oxygen. And that means put them on a nasal cannula, 2 liters, 3 liters, 4 liters, 5 liters, or you may even be able to use a mask and put them on just a little bit more than that. We have other masks that increase the amount of oxygen that we deliver. And so that's the answer. Increase the amount of oxygen that you're delivering to the patient. However, the next level is that if you already have the patient on about 60% or more, now this here is a non-rebreather, this thing delivers between 60 and 100%, depending on how good of a seal that you have on the patient. So if you have somebody on a non-rebreather, then they're on 60% and above. And if their PaO2 is still bad, then you need to switch to that other type of alveolar problem that I've talked about. And you need to use CPAP or BiPAP. And if you're on a ventilator, for you respiratory nerds already, then you're going to be using PEEP, going to increase the PEEP. But you're increasing the positive index-to pressure, or in other words, expanding the alveoli so that the good alveoli that you do have, you can optimize with gas exchange and capitalize on their ability to do gas exchange by making them bigger, thinning out the alveolar capillary membrane, and really stretching that space so you maximize that gas exchanging space. But that's the general answer. Now, remember I said if your PaO2 is severe hypoxemia, and in other words, you're putting on oxygen, maybe you have them on 100%, 60 to 100% oxygen, and yet their PaO2 is still really low, that's when you have basically an oxygenation emergency on your hands. You're probably this close to a code, if not a code already. But what you are going to want to do is treat that patient as an emergency. You're definitely going to want to stick an ET tube in them. That's going to be the primary indication. ET tube, and then put them on life support, mechanical ventilatory support. And this is important to understand that we think about a ventilator as if somebody's not ventilating enough. By the way, if you have a hypoxemia level of PaO2 of 40 or less, you probably aren't ventilating very well. But even if you were, then we would use a ventilator just to treat oxygenation problems. And a lot of people forget that. In fact, if the PaO2 is less than 40, the answer is to intubate and then put them on a ventilator just so that we can treat their oxygenation problem. All right, well, I hope that's been helpful. This is Dennis Stanley with Respiratory Sensei, and we talked extensively and very nerdy about the PaO2. And we'll talk in connection with other gas values like the CO2 and the bicarb and the pH. So please watch those videos as well so you can get the whole picture on ABGs. And we'll also have some videos coming up. Please hit the notify button so you don't miss them on collectively looking at ABGs and how to interpret collectively all of the values together and decide what you need to do. Again, Dennis Stanley, Respiratory Sensei, please like this. Please subscribe if you would. And let other people know about the channel. Share it if you would. And then give us a comment. Tell us what else you'd like to see or ask questions. We'll be happy to answer those as we go along. And as the Japanese would say, ja mata.